Happy Palm Sunday.
Joy 99.7 FM.
Most definitely, Felix Owusu. Program is ready to serve. Yeah, we've been doing Nocturnal and Enuresis, better known as Bedwetting. Got in the studio with me Dr. Franco Susetre, consultant pediatrician and head of the Rebecca Akufado PICU Pediatric Intensive Care Unit. We've been learning what causes bedwetting. Does it run in families? How do we assess, conclusively diagnose? Today we want to do treatment and management. All the beating, the punishment, the kakadro, etc. Where does it fit in? Dr. Osusetre, you're welcome.
Thank you, and thanks for having me again.
Right, great to have you. I did a whiz stop. It's strange when you're behind time. You're trying to beat time. That's when you get all the Sunday drivers and the roads that have been blocked for all sorts of unreasonable reasons. But I'm here, and I'm glad to be here, and I'm glad you're here. And to you, my listeners, thanks for tuning in and staying with us. Happy Palm Sunday. Right, irrespective of the celebration, the observation, we established last week that bedwetting is a serious, very common problem. With the help of Dr. Osusetre, we got to understand that there's a part of it that could be and possibly is hereditary. It runs or is more common in boys than girls. We also learned that before the age of 5, typically, we should not be stressing a child about bedwetting, though we do expect that progressively they will gain and achieve bladder control, right? So if you've been stressing your child below that age or even below 6, you may be stressing them unduly. We also learned that there's primary enuresis. That means your child never gained mastered bladder control, and therefore has never been dry, so to speak. And there's secondary where they did master, achieve, attain, and for some reason we lost it. That's my attempt at a summary. Doc, anything I've left out?
No, I think that's a very good summary. The only little thing I want to add is maybe just retrace how urine is produced and stored.
Right. Okay.
Urine is produced by the kidneys, and then it goes through certain tubes called the ureters, right down to the bladder where it is stored. And then when the bladder gets full, it contracts, and then the urine comes through the urethra.
Okay.
And we void it out. The production of urine is under the control of the brain. Mm-hmm. The brain produces certain chemicals that will regulate how much urine you should produce. In other words, if the amount of water in you is not much, the brain will make it such that you produce less urine.
Okay.
And then if you are in an environment where there's too much, the
so it's
environment is very cold.
The brain is preventing you from becoming dehydrated.
Dehydrated, yes.
Okay. Right, okay.
And if you are in a very cold environment, or if you are drinking excessively, then the brain also regulates it to produce some chemicals that will help for you to pass a lot more urine. So it is all aimed at making sure that you don't overload and you don't underload as well.
All right. Great stuff. So it's controlled by the brain, and we did learn last week. I'll take a stab at it and give it back to Doc. That the brain should be able to sense when the bladder is full and there's a need to void, and it gives out some chemical signals, and this allows you to void. Those signals are changed somewhat when you are asleep, right? But you should still be able to hold your urine after mastering control, and the messages and the signals should be able to help you achieve that. So when we started learning about possible causes, I remember Dr. Ususetra sharing with us, sometimes the brain's nervous system is not fully developed, and therefore these messages and these controls are compromised. Sometimes we hear that the person is a deep sleeper, and therefore they sleep so deeply that they do not respond to the indications, right? The urge to void or to empty the bladder. We also heard about a few other things about the size of the bladder and many other things, and possible infection. Doc, have I left anything out there?
No, it's just that I think you came out. You did mention about primary and secondary. Mm-hmm. The fact that if it is primary, then not so much of a problem. Mm-hmm. Chances are that you are just taking a bit longer to master your act of containing urine.
Okay.
But it's the secondary one that we tend to worry about, because almost invariably there is an underlying pathology, be it a problem with the urinary tract. You may have, say, for example, an infection along the urinary tract. And because of the irritation, there is that urge to void frequently.
Okay.
So if you are asleep and then you are not able to, then you bedwet as opposed to waking up 4 or 5 times. Yeah.
Okay.
We also mentioned diabetes, which is also known to produce a lot more urine because you are excreting sugar, and sugar will attract a lot of water by osmosis. Those of you who remember your science.
Okay.
So you are going to get a lot more urine passed in the night, and that, if you are not able to keep up with the waking up, then chances are that you're wet bed. And we also mentioned the worms, that peeing worms, and certain habits. I mean, there are some children that will want to drink a lot of water just before they go and sleep. If they're able to wake up, that is fine. But if they are not able to, then they will wet their bed.
Okay.
And then we also talked about certain drinks consumption that have got a lot of chemicals, like caffeine-laden drinks, for example. They have that ability for you to pass a lot more urine. So if you take it before you go and sleep and you're unable to wake up, chances are that you are going to pass urine. So these are the secondary things that we think about.
Right.
But not to be forgotten is the psychological aspect as well.
Right.
We do have children who are abused. All sorts of abuses, could be physical, could be sexual,
Abuse,
could be emotional,
post-trauma,
psychological, everything
right.
can cause a child to regress. A child who has mastered that suddenly starts wetting bed, maybe because daddy has gone to work somewhere, and the child misses daddy.
Okay.
And so that is their way of, complaining, so to speak. Let's say you know that there's a problem.
Okay.
Or so there are certain trauma, or
Right.
maybe school, somebody's bullying the child, or so.
Okay.
Those things can make the child regress. And
Okay.
then, pass
Great, right. Lots of different antecedents or possible causal factors that may lead to your child wetting their bed or being unable to hold the bladder and to hold urine when they are asleep. In the instances that I'm discussing with Dr. Osu Setre, let's mind and be or take into consideration the fact that during the day, this child typically is continent. They are able to hold their urine typically, right? There are those who void or wet or soil their underwear, not only with urine, but sometimes with feces as well. But we're focusing on nocturnal, nighttime, involuntary voiding, involuntary urination. Involuntary meaning that the child does not do it on purpose or deliberately, right?
Precisely.
These were the things we underscored last week. We are back in the studio to try and fix it. If I can use that phrase, fix it. Treatment and management. Those two things mean different things, right? And you need to understand that. I'd also be interested when you call us or WhatsApp us. What have you been doing? How have you been managing your child? Last week, I recall we had Rukaya, who called in and confessed, gave testimony to the kakadro and the other things, and she feels now her child may be somewhat traumatized and is a bit jittery, even when he's doing it in the right place at the right time. Share with us. WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. The program, wherever you are on this globe, is Ultimate Health, your ultimate guide to healthy living on Joy 99.7 FM with me, Nortey by nature. And I'm with Dr. Frank Owusu Setre. He's a consultant pediatrician. It's an extension, in a way, of my series with the University of Ghana Medical School faculty. He heads the Rebecca Akufo-Addo Pediatric Intensive Care Unit here at Kolebu in Accra. So if you have any questions, concerns, experiences, confessions, testimonies, share them with us. Right, Doc, so we got a sense of this. And one of the things that we also touched on was the fact that if your child is, apart from the infections and things, if your child is constipated, then there's pressure on the bladder, and that could also cause involuntary voiding.
Yes, not only on the bladder, but on the nerves around the pelvic floor. So that can impair or interfere with the normal sensation for you to void urine.
All right.
And if you don't feel it, you don't void. And then if you are asleep and it comes, then you may not even feel that the urine is coming. That is a problem.
Okay.
So constipation is one of the things that we can actually treat, maybe by use of stool softness or some purgatives. We should be able to get a feces out, and then a child who was wet in bed because of that now becomes free.
All right. We'll be shifting gear to look at and consider the treatment modalities available. Some are pharmacological, meaning that they involve the administration of drugs, and some are behavioral, right? We'll talk about that in a second. But Doc, let me get your sense or your word on this. I know this is not a program focused on toilet training, but is there any aspect of this process where we seek to train the child to acquire these skills, and indeed it constitutes a developmental milestone of sorts, right? Is there anything that can go wrong with the toilet training process that could also predispose a child to bedwet?
Yes, I think I don't qualify when it comes to the Freudian principles. But the little that I remember,
you shouldn't say that when I'm with you.
yes. That's why I'm being very cautious, because
right.
I know my knowledge is very limited when it comes to that. But how well you train a child has a way of impacting on his or her personality.
Okay.
I remember if you don't train the child, it affects the way they behave.
Okay.
Like vivid example I remember back then in Legon, when we were being trained by who? By Nortey Dua. For those of you who don't know, he's my lecturer. So one of the things I remember.
For a second, Frank, I was worried you're going to say I did your toilet training.
That's a good one.
No,
Yes.
those are different fundamentals.
Yes.
Yeah, go ahead.
So my understanding, again, I stand to be corrected, is that if you train the child very well, then you have those children that are very neat. They keep things
Right.
where they're supposed to be. And for those that are not trained very well, then they are the careless guys that they can just leave anything.
So it can lead to some personality traits.
Certainly.
The
certainly.
way toilet training is handled. Okay.
Yes.
And
So-
yeah, go ahead.
Yes. So, just to answer your question in a nutshell, is that it is more of a social problem
Okay.
than medical or biological
Okay.
problem. Like
If we look at it that
you
way.
rightly
Yeah.
mentioned last season, last
Week, yeah.
that we are all born with that innate ability to be able to train certain things.
Okay.
But just as in the case of animals, they do anything anywhere.
Right.
We also have that animalistic tendency.
Right.
But social is not acceptable, so we need to.
So it's part of
also
your
now
socialization.
precisely come
Right.
up,
Okay.
and do things acceptably, so that we can integrate into society without so much of a fuss.
And call ourselves adults.
Precisely.
Okay, great stuff. 22 minutes past the hour of 2 on Joy 99.7 FM. We're having this very interesting discussion on bedwetting with a pediatrician. We're learning, but for many families and indeed many of the afflicted, it's not a funny issue at all. It's a source of trauma, distress, embarrassment, sometimes humiliation, right? That's why we're talking about it. So the psychological, sociological components of it are very, very critical, and we should know them. And also, sometimes some of the methods to get you potty trained and toilet trained and all that are pretty crude,
Harsh, yeah.
draconian, and harsh, right? And they may also affect the child's normative development. Okay,
Yes. So you may have
yeah.
people who may just conform,
Yeah.
and those that will rebel in
Okay,
quotes.
yeah.
So different personalities, different people reacting to the same stimulus.
Okay.
So some people will go along, but some will rebel, and
Okay.
then the end result is that even when they can, they will just not do it.
Okay.
So like you said, there is no need for any draconian measures.
Okay.
We need to be
All right.
pathetic as a way of
If in
finding
doubt, you
solutions.
learn it and you acquire the knowledge. I know we like to Google, but there are professionals who can assist you in some of these areas. Okay. My WhatsApp is active 055 11 11 997. We're live on Facebook and YouTube. And shortly, I will activate the phone lines. If you've just walked in, joined us, this is Ultimate Health on Joy 99.7 FM, Palm Sunday edition, but we're still talking about bedwetting. And we have a consultant pediatrician in the person of Dr. Frank Owusu-Setre from the University of Ghana Medical School. He's at Child Health in Kolebu, and he heads the pediatric intensive care unit named after our First Lady, Rebecca Akufo-Addo. Right, let me see now. I got stuff... there's some drips on my WhatsApp, and let me see if I've collected enough to void. Right. Does the size of a child's penis cause bedwetting? Like a 15-year-old who has a small penis, does it mean that his organs are not well developed? If it is, how can it be treated? They're bringing in the size of the external genitalia here of the male, right? They don't associate it with the females in this question,
At all.
right? I know Doc will deal with that. You're talking about the opening or the pathway, right? Could that be implicated as a problem or a diagnostic criteria? This one says a 13-year free and well-trained child is still bedwetting, and all talk from trained psychologists is not yielding any good results. What advice can you give? All right. It looks like we'll share that one, right?
Yeah.
And then, good day, Nortey. My name is Laila or Layla. Okay, wait, hang on a sec. I love your program. It's always very educative. Thank you. Well, kudos to Dr. O.S. That's you, eh? Also,
yeah.
you have some people who call you OS.
Yes,
Okay.
that's my initials.
All right, yeah, I know. This is a Layla or Laila. He is a very good pediatrician, and he knows and loves his job very well. Please tell him Layla says God bless him so much for his good heart and contribution towards the development of Mother Ghana. Right? So love coming out to you. It's always the women, eh?
Yeah.
But last time it was, to be fair, it was his wife. Mrs., please, we are live on Facebook and YouTube. Don't miss him this time live. Husband is here live in color, and some people say dialect. All right. If you have any questions, concerns, 055 11 11 997. Shortly, I'll reach that point where I activate the phone lines as well. You can follow us on our Facebook and YouTube platforms. Yes, Doc, you were going to add something.
Yeah, so I'm not very sure whether I can respond to the first question.
The size of the
penis.
penis.
Size of the penis.
All right.
It's not so much of the size, but the opening.
Right.
Boys especially have got something we call a posterior urethral valve.
Okay.
It is an anomaly, something that is supposed to go away, but it doesn't go away. It persists in certain people, and as a result, they tend to hold urine. Not that they hold the intention, but the urine just doesn't come. And then when it overflows, then you can have it dripping or dribbling.
Okay.
And then so they wet bed.
So that's it. Well, hang on a sec, Doc. I'll need you, or I'll plead with you to take that slowly for the benefit of my listeners.
Okay.
Posterior
urethral valves.
Valves.
Yes.
Okay.
That is an anomaly, something that every boy is born with, but it goes away at a point.
All right.
But in some children, it will persist.
Okay. Beyond the name, what I understand what a valve is, but there's something wrong, compromised, or abnormal or dysfunctional about the valve. Can you explain that to the listeners?
Okay. So the valve is supposed to be able to open to let the urine come out.
Okay.
You know, depending on the outlook.
Okay.
If urine is supposed to come out this way,
Straight,
then it should be able to open that way. But if
Right.
the valve is this way, then
Okay.
it can't open.
right.
So it is the abnormally placed valve
Okay.
that stops the urine from flowing.
All right.
And so the urine will continue to be produced, it will continue to accumulate. And it will get to a stage where the body cannot contain it anymore. So
It comes forcefully.
overflows.
It overflows.
Yes. And the thing is that the person may not even know it.
Okay.
A clue to this condition is to look at a child's urine stream, a male boy.
Right.
If the urine stream is not good and the child is wet in bed, then that warrants investigation.
Proper examination
Yes.
of the structures, of the penis,
yes.
the valves, the opening, etc.
Precisely.
All right.
But the size of the penis is really regulated by hormones as you get to the adolescent stage.
Okay.
And so I know that some people will compare. We all attain puberty at different times. So if you use the age cutoff and you compare, you may think that somebody is maybe more endowed than the others,
Yep.
or the other, and you may be worried. But it is not really about the size.
All right.
It is the hormones. When it gets to that stage, when the body will have to produce the hormones and cause the what you call the secondary sexual characters, one of which includes enlargement of the penis and the testes.
Right.
That will happen.
Great
I don't think
stuff.
it should worry.
Right. 28 minutes past the hour of 2 on Joy 99.7 FM. The program is Ultimate Health with me, Nortey by nature. I'm learning about all these valves and all the plumbing that goes into your urinary system and how the urine comes out, where it's produced, and why and how it should come out at the right time in the right place. We're talking about nocturnal enuresis, involuntary urination, bedwetting, if you like, with a consultant pediatrician. Okay, so this is not a grandmom's tale or folk tale. We're looking at the clinical features, the presentation, and what really constitutes a problem. Don't forget, last week we emphasized and underscored that developmentally, most children or the average child will get this right by the age of 5 or 6. All right. So if you're stressing a child younger than that, developmentally and clinically, you may be doing the wrong thing. But if in doubt, do consult a professional and get an assessment. Okay. That's what we're catching up on. My phone lines are active 0302 216 541. Those are the healthy buttons to push if you have the need and the urge to void in the form of questions, right? Or to share experiences, okay? This is the right place, the right time. You can do that. 0302 216 541. Ultimate Health on Joy 99.7 FM. We're going to be moving along and considering some of the interventions. This one says, my daughter is 9 years old with all the training, but she still wets the bed. What could be the cause and what can I do? This is Chief from Boma, right? Chief, you'll agree with me. We don't know how you did your training. We only know your daughter's age. There are many things we don't know, but I'll still pass it on to Doc as we tiptoe into interventions, treatment, and management. Doc, anything you want to say?
Yes. So 9 years is still. I mean, it's a bit advanced, but it is not. It's not way advanced. It's not something that it should be too worried.
Okay.
It's not even in the teenage years yet. So
Right.
Maybe we'll need a lot more training.
Right.
Maybe what we will talk about may be helpful.
Okay.
But I don't think there is a need to stress the child.
Okay.
What you probably would need to do is just to make sure that those conditions that we talked about are excluded.
Right.
Once she's well, has a clean bill of health,
Okay.
then we can wait
Okay.
for the training to continue till she attains
Okay.
that milestone.
All right. Because we've accepted and we've been told, informed, taught, educated that it is not a deliberate act of the child, we need to be sensitive in managing it or treating it. Very often the temptation is to do this very harshly and with punitive or painful aversive measures. Right. We're going into those areas now, right? So how do we address this? How do we treat or manage nocturnal enuresis, Doc?
So we really mentioned the pharmacological and the non-pharmacological.
Okay.
The pharmacological, which involves the use of medications,
Okay.
is always the last resort.
Right.
So
Why
we
so?
talk about what we can do.
Okay.
Because like we said, a lot of people, even without doing anything, will be able to train themselves to attain that, no
Right.
matter how late it is,
Okay.
even in adulthood. Still,
Right.
they continue the training themselves.
Okay.
And at a point, they stop bedwetting. So there is no need to rush into giving medications. Besides, the medications may not always work.
Okay.
And obviously, there are side effects also to be considered.
Okay.
So we try as much as possible to try the behavioral aspect of management.
All right.
And that involves, I mean, we have the self-help, and then what you may have to seek maybe the intervention of clinical psychologists.
Right.
So if we talk about the self-help, what parents can do at home,
Okay.
they may need to get a child to understand that whatever is happening to the child is not as a result of the child's inactions or maybe laziness or anything.
Okay.
That it is the fact that he or she is having difficulties mastering certain aspects of controlling that.
Okay.
And it is a shared responsibility.
Right.
So once we rope in the child, then we have an ally. So the child is involved, is an active partner, and the child is likely to come along with every effort that we
Right.
put
So
in.
partner with your child. Let your child understand that this is a problem, right? It's quite common. It happens to some children through no fault of theirs, and we are going to
Precisely.
work jointly to seek and work towards a solution.
Yes.
All right, great. Captured.
So the no teasing, I mean, you have to institute a no teasing policy.
Okay.
There is no reason why anybody should be teased because
No
the person
ridicule,
has-
no teasing.
Absolutely.
All right.
And certainly no room for them carrying their mattress or mats and then parading them along the street, or maybe punishing them, beating them, using all sorts of concussions as a way of punishing.
All right.
That is no.
Okay.
No.
Do not shame the child who is bedwetting.
Precisely.
All right. Support them, partner them. Right. And indeed, in many instances, I'm going, Doc, I need your view on this. Those methods may worsen the situation.
Yes, they do, because like we say, it gets to a point where we all rebel.
Right.
As part of the developmental process. At a point, you begin to question why you need to do all sorts of things.
Right.
Like somebody with a chronic condition will take medications and then becomes an adolescent and wonders why me alone? Why isn't my sister taking?
Okay.
Why? So that is natural. You
Okay.
have to let the person understand the reason why he or she needs to do
Okay.
what the person does.
Okay.
So there's definitely, definitely there's no need for us to shame
Okay.
or maybe exert punishment. We're
Right.
just going to
So
worsen the situation.
this-
But we should be empathetic.
Right.
Let them understand that, again, it is a shared responsibility, something
Okay.
that we are going to go together. One of the things that parents must always avoid is the easy way out of putting them in diapers. So
Alright.
you have somebody, let's say 5, 6, 7, 8, who is bedwetting, and then because you don't want the bed sheets or maybe the mattresses wet, so you put them in diapers.
Okay.
There is not going to be any motivation for them to come along with the methods that we're going to talk
Don't
about.
constrain or sentence your child to wearing pampers, diapers, or any form of
No.
padding or
Absolutely.
whatever. Right.
Yeah.
That actually heightens their distress,
Yes.
and
And they have
also
an option.
it also makes them more and more different from the average child or their siblings.
Yes.
All right. Why do
Yes.
I wear pampers? And that could also be another source of ridicule and whatever.
And stress.
So avoid
Yes.
that.
Avoid that.
Okay.
Definitely. Yes.
Some of
And
my
then-
listeners, Doc, will say, Charlie, time is going, we are still wet. But we are building
Yes.
up. This foundation Dr. Osusetre is going through is very important because you're trying to establish rapport and a sustainable partnership. This is a journey and not just a destination. Very often, parents are fixed on the destination, which is you are dry
Yeah.
and we are free, right? But it's a journey and we are packing for the journey. So that's what Doc Osusetre is building up to. So stay with us. Don't go anywhere. This is not the time to go and pee. Right? Stick with us on 99.7 FM. We're talking about bedwetting with Dr. Franco Ususetre, a pediatrician. All right. So we built this platform. The child has some understanding, though they are still somewhat frustrated. Right? Where next?
So the parents will have to understand that the aim is to get a child to wake up
Okay.
and not to get a child to sleep through the night.
Okay.
So get a child to wake up to go and pee.
All right.
And that will mean that we will have to make it easier for them.
Okay.
So sometimes we may have to, if the place is dark, we may have to make sure that when they wake up, the place is well light or
Right.
well lit, for them to be able to go and pass the urine.
Okay.
And we call that the self-awakening method. We
All right.
want them to be able to wake up by themselves.
Okay.
And the reason is that as you do that, as you get them to wake up, they are motivated
Okay.
to wake up.
Right.
And you can then institute what you call a rewarding scheme.
All right.
That, okay, so if you're able to wake up, you get maybe a sticker a day.
Okay.
If you get, say, 4 or 5 stickers, and a sticker means that you're able to,
Right.
go through the night without
a dry
wetting the
night,
bed.
yeah.
Yes, so you get a sticker. When you get 5 or 6, you go out.
Okay.
Not him, not the child.
Right.
But the whole family will go
All right.
out, so that the child now has
So we are
something
celebrating.
to motivate him instead of being the outcast. He is
Right.
now the one taking the family out. So there's
Because he
something to look for.
achieved
Absolutely.
some bladder control.
Absolutely.
Okay. 38 minutes past the hour of 2. If you just joined us, we're learning some of the treatments and managements for bedwetting. You've heard Dr. Franco Ususetre, a consultant pediatrician, telling you, partner your child. Don't scare them. Don't shame them. Don't make them feel guilty, right? It's still something you'd want to correct. But with their partnership, make it conducive and easier for them to wake up on a voluntary signal, right, and go and void in the right place. He added, make it, lights should be on, the toilet should not be spooky or scary, and so on and so forth.
Yeah.
We are putting ourselves in the shoes, if not the bed of the child, in order to partner them to do this. All right. So all this makes it easier to do, and we will be less reactive and insensitive to slips and regressions.
Yeah.
We will make some mistakes along the way, but we are building a capacity.
Yeah.
And the methods and the strategies must not be damaging. All right. If you have any questions, concerns, WhatsApp 055 11 11 997. I've got this from Dede in Maryland. She asked it last week, but we closed. She was asking, you mentioned that some children, because of the toilet not being too clean in school and stuff, they hoard their urine. for over 8 hours, and then when they get home, and some of this could be part of the problem profile. She's asking, children who do that, doesn't it compromise or affect or damage their bladder and kidney?
It predisposes them to recurrent urinary tract infections.
Okay.
And if it does ascend to the kidneys and the rest, then it can cause problem.
Okay.
It is something that is not to be encouraged at all.
Okay.
So if your child is holding urine, and especially stools,
All right.
sometimes they soil themselves, they have accidents
Right.
because they are so used to holding it,
Right.
and then they get overflow, they don't even see it.
Okay.
Then it becomes even more difficult for them, more embarrassment for them to.
And the
now
school should
mingle.
make sure that their toilets are worth visiting.
Absolutely.
No matter your age,
Absolutely.
go and check your child's school toilet. What is there? That place that they are supposed to download, please. Go and peep, and you may understand why maybe they are holding, refusing to void, and then at the wrong place and time they are voiding. It could be related, right?
Yes,
Don't just
could be.
pay school fees, drop them, and then zap, you are off.
it.
Okay, so do check these things. All right, Doc.
Yeah.
Please go ahead.
Yeah. All right. So back to the self-awakening. I think one
Okay.
of the things that you probably may need to do is to get them a small potty very close to their bed.
All right.
The aim is to get them to wake up and wee,
Right.
not to wee in bed.
In the bed. Okay.
So if you make it easier, maybe bring the bowl or
All right.
the
Proximity.
pot very close to them, yes, then we are going to win.
Okay.
And to get that right, it is important that we rehearse with them.
Okay.
So during the day, you let them go and pretend like they are sleeping and
All
they
right.
have felt the
We
sensation.
practice it.
Yes.
Role play.
Yes.
All right.
And so they themselves look forward to it.
Okay.
They psych, they condition their minds.
All right.
And then when it happens, really, they are able to
Practice makes
respond.
perfect.
Yes.
Right.
The other method of awakening is parental one.
Okay.
So sometimes the parents will also have to put in a little more effort. And then the
Night duty.
admonition here, yes.
Night duty.
Okay, so the admonition here is that in order for the parents not to stress themselves too much, they have to make sure they wake them up just before they themselves go to sleep. I mean,
Right.
you cannot stay awake.
Assumption
because you
being
want
that
to.
your child goes to bed and has a bedtime before yours.
Yes, so you should institute
So
that.
discipline at home is also part of
Precisely.
giving the child a structure that serves as a guideline and clearly demarcates deviations.
Yes,
So if
and
your
you'll
child
enforce.
sleeps before you, what you're saying is that when the parent is now retiring to bed, that is the time to wake the child and make sure they void.
Yes.
Okay.
And even here, when you wake him up, you don't have to hold him. Well, forgive me, I keep saying him. I mean, I'm using him. It applies to her as well. So that the person goes to the toilet himself
Right.
to make sure he pees into the bowl. He does whatever he needs to do and goes back.
Okay.
So that it becomes, again, you are
Something
trying to condition.
they do themselves.
Yes.
Bedwetting beyond aid.
Yes. The difficulty
Right.
is that there are certain children that by the time the parents go and wake them up, they've already done
Too
it.
late.
So that means the parents would now have to wake them up earlier
Okay.
than anticipated.
So you use even that mishap to get a baseline. You can
Precisely.
profile and say, around this time, Charlie Jr., wayadada, right? So I shift my time ahead of that. Yeah?
Yes.
Okay.
Let's say you used to sleep 3 hours after him. By the
Okay.
time you go, he's done it.
Okay.
So then 2 hours after he sleeps,
Right.
you go and wake him up.
Okay.
And then you let him go. You
Okay.
guide him, but you let him so
All right.
that if he wakes up,
Right.
he won't need
He won't
your
he won't
touch
wait
or
for you.
anything. Yes.
All right. Great
Yeah.
stuff. 44 minutes past the hour, 2 on Joy 99.7 FM. My phone line is active 0302-216-541. We're looking at treatment and management of bedwetting with Dr. Frank Owusu-Setre. If you have any questions, concerns, experiences, share them with us on WhatsApp 055 11 11 997 or call us directly and we'll talk about it. This is a whole big partnership. The child wakes up or is helped to wake up, right? All of this is non-pharmacological. No drugs have been used. We are training, we are acquiring a skill, right? The same way you learn to type, to WhatsApp and other things, we're saying with the right conducive conditions, a child can be helped to do this.
Precisely.
right? And the pediatrician would have done an assessment to eliminate any other more serious or residual problems that need to be addressed. No infection, no diabetes, no constipation, no that. And then we are following this path
Precisely.
together. Now, Doc, very quickly before we go further, some parents, of course, like the mishap you just mentioned, we are being very calm in this studio. So you go to wake your child, already you're not too keen or happy on disturbing your sleep or your time in the evening to wake up this child, unlike his siblings or her siblings. And then you get there and they've done it already. Please, a word on the response. If you get there and it has happened already, Hotmail has already been downloaded. What is the most supportive response of a parent who had actually set out to go there to prevent something and it's happened?
Yeah, I mean, so you just have to. I understand how frustrating that could be, but you have to control yourself, keep your calm. You still wake him up, get him to change the beddings. He must be involved in changing the beddings,
Right.
the cleanup, and then he can go back to sleep.
Okay.
And hopefully, if he's done it, chances are that he may not be able to do it again.
Okay.
But then you need to adjust the time
Okay.
that you need to wake him up.
So you are
But
using
in all,
that,
we
yeah.
have to be measured.
Measured. Okay.
And we need to exercise a lot
Some
of
restraint.
self-control, because it can be very
challenging for a
irritating.
child.
Yes.
Right. Okay.
Yeah.
And I did mention last week that if you're not careful, the child builds a secondary emotional challenge on top of the enuresis, right? They become very jittery. They are not confident. Their esteem is challenged, if not battered and damaged. So you are doing this carefully, knowing that it's an investment and not a cost, right? You are investing in your child's mastery and their development. If you have any questions, concerns, 0302-216-541. This is Ultimate Health on Joy 99.7 FM. We're talking about bedwetting. What are your challenges? What have you been doing, right? And we're trying to discourage the harsh, damaging, traumatic, draconian, crude methods. But do share with us on our phone line 0302-216-541. Dede in Maryland comes back and says, Doc, do you provide remedies other than surgical for the valve defect that you just talked about?
No, that has to be surgical.
It has to be
Yes,
surgical. Okay.
There's a term, we call it fulguration.
Okay.
You need to go and remove those valves, else it's not going to go away. And the urine will continue to build up,
Okay.
and then it will destroy the kidneys, and the end result is that you probably will need kidney transplant.
Okie dokie.
So that is always an emergency.
All right. Okay. Somebody is sending something which says, this is what happened on my new land. Okay, we're not doing land on property.
All right.
Right?
So
yeah, go ahead.
Yes. So the other method to help the child wake up is what they call the alarm system.
Right.
And we have the voice one, or the bell, and then we have the tactile one.
Okay.
And it basically works in such a way that with the first sense of the child will wear it.
All right.
And as soon as it senses urine, it wakes the child up.
So you don't just have the audible alarm, you have a sensor
Yes, we have
in the
sensor.
child's underwear.
Yes.
So it senses the slightest moisture,
And then it goes.
then it goes off.
And it wakes the child up.
Okay.
So the child will now wake up, go and wee, and cleans if he's passed some urine
Right.
already.
Okay.
He will clean it up and then change his beddings and then goes back to sleep.
Okay.
So that is the sensor. For that to work, though, you need to be able to wake up.
Right.
And that is always a challenge
Right.
when it comes to the deep sleepers.
Okay.
It's always difficult. And those are the ones that we tend to try the medications
All right.
on.
Okay. Just to chip in a bit, we know a lot about sleep stages and sleep cycles. So we are able to help parents time the duration for the alarm and get the best, or to yield the best results. Okay, there's light sleep, there's deep sleep, and so on and so forth. So when you hear something like, well, 1 hour after sleep, do this, 1 hour after sleep, you are likely to be in the deeper stages of sleep as well. So the idea is to intervene before you get to that point, right? And this is also very, very, very important for you to know in order to help your child. And you should also be able to explain this with the child and be very observant as a parent in collecting data which you'll share with your pediatrician or your psychologist. This is the time he typically voids. This is the time this happens. And so we put the timer at this point in order to prevent it. Okay. Yeah. All right. Still no phone calls. We're still in business. So these are all behavioral, and these are in strong partnership, positive partnership with the child. We haven't mentioned kakadro. We haven't beaten them. We haven't taken them to the village square, etc., or the marketplace. All right. Neither have we put them on social media or Facebook or any other place or platform of shaming. Very important. Siblings should be part of this program so that they don't be squeaking things and teasing, or you hear a fight in the hallway and it's about this issue. All right. Okay, Doc, where do we go next?
So the next, if all these behavioral things are not working, is to use pharmacological
to use drugs, medication.
That is if it is still the primary. If
Okay.
it is the secondary, then that is where we call in the
Okay.
clinical psychologist
Right.
to try and deal with them. If the child is maybe rebelling
Okay.
because of something, maybe abuse or something.
Doc, just a second.
with
You
that.
use this word rebelling. For a lot of parents and a lot of listeners, this must be a choice. You don't rebel accidentally. So can you just caption that?
No.
How do you want us to capture or understand that?
Yeah, it is not something that a child does. The
All right.
child is
Like
I
a
don't
normal
know.
reaction
Yeah,
to
normal
frustration.
reaction.
To
Yeah,
frustration.
Great.
Right.
Yeah. So like the child is also now saying, okay,
My
whatever
bread.
I do, you are not happy. So
Boys and the girls
okay.
are bread.
Yeah, bread.
Okay.
Yeah,
Right.
So they can rebel.
Okay.
And we don't want that.
Okay.
So sometimes if a child is rebelling,
Yeah.
it is a way to tell you that something is not right with me.
They're giving you feedback.
And that
Right.
you should now maybe pay a
Okay.
little more attention than you've been doing.
Okay.
So that's where some parents may be able to get a child to talk. But almost invariably, you will need the services of a clinical psychologist who's
Alright.
trained to be able to get a child to
Alright.
voice out what's the
Right.
reservations or the exact cause.
All right. The clinical psychologist or the behavioral specialist doesn't come with your baggage, right? You have a lot of baggage, a lot of insults that you can download reflex on your child. The helper, the mediator, the professional comes without that and is better able to help your child, though you know and live with your child, right? That is why this is also important. You can say your head like your grandfather's crooked head, your this and that and that and so on and so forth, your nose and your head like a chamber pot, etc. You're not helping, you are inflaming matters. So this is where the professional partnership comes in. Yes, Doc, let's talk about the drugs quickly. We have about 8
the
minutes. Yeah.
medications, we have different types of medications. So we have one that will help with production of urine. It is
Alright.
going to limit the amount of urine produced.
Okay.
And that is called a vasopressin.
That's
We give
right.
it to the children at night, especially for those that will go camping or they want to go for a sleepover or something.
Alright.
Then we give it to them so that we know that the amount of urine produced is going to be
Right.
minimal. And so they are not likely to.
So this drug is really doing what the chemical messengers of the body should be doing
Yes.
in regulating the amount of urine
Yes.
that is produced.
Yes.
So we lower the production, and then we still do we do that alongside the behavioral voluntary control?
Yes, we do.
Right. Okay.
We do. We do. And then the next medication that we give is aimed at targeting the bladder.
Okay.
The bladder will have to contract when it is full.
Okay.
It will have to contract for urine to come out.
Okay.
And we can give medication that will rather relax the bladder. So instead of contracting, it relaxes it. And that is not going to cause urine to be pumped out.
Okay.
So the oxybutynin and then the hyoscine or the propanthyl bromide, those are the medications we use.
Okay.
And then there's this medication, imipramine,
Trophanil.
that
Right.
is used. I mean, it's used commonly. There's that medication. There's that mechanism is not so
Right.
known, but we know that it relaxes the bladder.
Okay.
And it also helps in reducing the intensity of sleep,
Okay.
so that with the slightest feeling of your bladder
right.
being full, you'll be able to wake up.
Okay.
Yeah.
The
But
objective.
the caution
Yeah, go
is,
ahead. Yeah.
the caution is that even with all these medications together with the behavioral, sometimes we are not able to win. And we still need to understand that the child eventually will learn to master
Okay.
how he or she will.
All right.
pass
So don't be
urine.
comparing the results with that of another child or another sibling. Over time, I do know from data that about 15% of children with these problems will, resolve their problems without any intervention. All right. The problem actually becomes the social setting, the social and psychological consequences and import of their bedwetting. Right.
Yeah.
If those circumstances are not too harsh, about 15% of them will correct themselves,
Yeah.
right? The others, it persists because of the social pressure, the psychologically damaging circumstances, and so on and so forth. So, whilst we're using drugs or psychological methods, we should bear this in mind, right? There are other things that make it traumatic and make a child jittery, emotionally unstable, and unable to comply, or should I say, work effectively with you to achieve these results. But Doc, just quickly before we wrap up, we know, and research tells us that with the drug treatments, there are kind of intermediate strategies. What you are ultimately looking for is that over time, you should be able to acquire and achieve and sustain and maintain voluntary control, right?
Yes.
There's evidence that shows that when you withdraw the medication, sometimes the problem comes back, and sometimes even worse. Is that right?
Precisely. So that is the reason why we are very wary, and it is basically our last option. And normally we do that when they are going somewhere, maybe like
Traveling,
going to secondary school,
sleepover,
traveling,
secondary
yes,
school. Yeah.
that is when we do that.
Okay.
But in my line of practice, I realize that a lot of parents are worried, and once they know that there is some medication available, they will push you
All right.
to
Somebody's
get it.
already
Yes.
asking, saying they missed the name. I knew
you
that
know,
was coming.
yes.
Is it,
But
isn't
it
it
is not-
prescription only?
I'm in Ghana. There are so many,
Yeah,
so many things that are supposed to
Right.
be by prescription, but the dosage and everything will have to be
Right.
looked at by.
Okay,
a-
and that
a
decision is
medical
made
doctor.
by a qualified clinician.
Precisely.
You don't go to the pharmacy, go and buy it and say, "Doc, Fawono."
Yeah.
Right. Most of these are oral tablets, aren't they?
They are.
All right.
They are none of them is
Injection or-
injectable.
right.
They are oral.
Okay.
But I will plead with our listeners that shouldn't be the first.
It's not your
line.
first
It should
line.
be given by a medical person who has
Okay.
looked at everything.
Okay,
And we
okay.
should give these children the opportunity for them to potty train themselves.
All right, great stuff. Good afternoon, Nortey. My son is 4 years and he does not wet the bed at night. But I've observed that as soon as he wakes up in the morning and urinates, he'll ask for water or a drink. Is it normal for a boy of his age, 4 years old? He's dry, but he loves his fluids.
Yeah, that's okay.
All right, that's
Yeah,
from
give it to
Maxwell
him.
in Achim Tafel.
Yeah, that's fine.
That's fine?
There's nothing wrong with that.
Okay, right. Almost touchdown time. I know there's a big match, so I can sense the sports guys, I believe, pacing up and down. But let me ask this: you did touch on the kind of snacks and drinks kids are taking to school these days, and there was some linkage you made last week. Can you just quickly?
Yeah, so some of them have a lot of caffeine.
Right.
And the effect of it is going to linger on and is going to let them pass urine.
Okay.
So it's best to let them avoid that if they can. If they cannot, then they should take it way before, maybe before midday.
All right.
So that by the time they go to sleep, the
All right.
effect will have worn out. Yeah.
Right. Dede from Maryland again. Is it wrapping the bed in plastic? You know, the Macintosh and things that we used to use, and it doesn't prevent it, but it's to protect the mattress.
Yes,
Right.
but the
is it
downside
hygienic?
of that, it is not.
Okay.
The downside of that is that if you sleep on that, you realize that it sucks water off you.
All right.
So it is not. It's not recommended.
It's not the
at
best.
all. No, it's not.
Okie dokie. Touchdown time for me. These are methods that take time. We explain them so that you can understand. There's a lot of psychosocial factors at play, right?
Precisely.
You are being compared sometimes unconsciously or consciously with siblings and cousins and all sorts of awful stuff, which makes it very, very challenging and traumatic. So let's be mindful that it can be complicated depending on the child. Your children have different personalities. So even though you can compare and say, oh, this one stopped breastfeeding at this time, this one walked at this time, this one was dry at this time, the parameters are not the same and the fundamentals may expose you, right? So be mindful and be kind to your children. And most of our health facilities do have a pediatrician, right?
Yes.
Or should have a
most do.
pediatrician.
Most do.
And your general practitioners, your family practitioners, family health or medicine practitioners should be able to assist as well in these things. All right. So I think we've done justice. We are on the way to being dry. We're not automatically dry because we've listened to Ultimate Health. But many thanks to you, Dr. Frank Usu-Setre, for assisting us. We'll get feedback and we'll see if we need to do something further on this. We didn't touch on encoporesis or fecal soiling, right? But Doc has touched on it and said that some children are withholding voiding for different reasons. And if you notice your child is soiling their underwear with feces as well, sometimes this could be of concern and check. And then the last thing I'll hit on is, hey, step into the toilet of your child's school. Step into your own toilet or the kids' toilet or their bathroom. There may be things there that are also part of the problem, right? So hygiene is a good thing to download, but there are many things you can do to make it more likely to occur. So those are the things I'll stick in there as I wrap up. Many thanks again and salute to you, Dr. Frank Owusu-Setre of the Kolobu Teaching Hospital, University of Ghana Medical School. He heads the Rebecca Akufo-Addo Pediatric Intensive Care Unit. We've been talking about bedwetting. My name is Nortey by nature, and last I checked, I was dry. Just kidding, right?
May I know which team you're going to support now?
Charlie Hazakis.
Okay.
I know it's Man City versus Liverpool.
Yes.
I grew up partially in Liverpool.
Okay.
Though when I was there, when I was there, I supported Everton, right? Because in the 70s, please, in the 70s, Everton was tough. Okay. These days, I don't even mention it. And plus, I had a liking for blue. Okay. Right. But in this derby, I guess the blue is Man City, and they're just across, Manchester. So, well, the best team will win.
All right.
All right. We're safe. Are you for Liverpool?
I never walk alone.
You never walk alone.
Absolutely.
All right. An Anfield man. But all the best. I think, Abek, is the sports team coming? Yeah, the sports team are coming, and I think it isn't in what? All right. I got a couple of commercials to run off, so we'll come back next week and do some more stuff. They can stay on Joy 99.7 FM. Don't go away. My name is Nortey by nature. I'm out.